So the CheckMate-9LA regimen is the most recent regimen that was added to our treatment arsenal. This was the first time in my knowledge where we had approval of the drug before we've actually seen any of the data. This is a combination of platinum doublet chemotherapy, histology specific, combined with dual checkpoint blockade using the PD-1 inhibitor nivolumab and the CTLA-4 inhibitor ipilimumab. But the unique wrinkle here is that chemotherapy was only given with the first 2 cycles, not with the first 4, and no indefinite maintenance chemotherapy. And the rationale, the strategy here is to provide a means to get that initial rapid cytotoxic control, to avoid that initial drop in PFS, to really provide that benefit for patients with aggressive disease or high burden disease, and facilitate that initial response. But then towards the cycles beyond the second round, to really lean more on that dual checkpoint blockade for durable benefit and for a more meaningful duration of response. When we look at the outcome from this Phase 3 registrational trial, over 700 patients randomized, there was a survival benefit. Now, it's important to look at the patient characteristics. About 30% were squamous, a little different from studies like Keynote-24, where it was closer to 20%. And if you look at the PD-L1 breakdown, we would typically expect about a third negative, a third positive low, and a third positive high. Here was about 40% PD-L1 negative, and so it's important to keep those populations in mind when we look at absolute numbers. But it was a randomized trial, and compared to chemotherapy alone, the chemo-nivo-ipi approach did provide a survival benefit. Overall survival was 15.6 months versus 10.9 months. It's a hazard ratio of 0.66. The 1-year survival rate was 63% compared to 47% with chemotherapy. Broken down by histology in the non-squamous group, we saw a 17-month OS versus 11.9, hazard ratio of 0.69. And in the squamous, 14.5 versus 9.1, hazard ratio of 0.62. In both squamous and non-squamous histologies, and really across PD-L1 subsets, the addition of nivo-ipi to 2 cycles of chemo provided a clear benefit over chemo alone. The control arms didn't necessarily underperform. If we look at the PD-L1 negative group, the survival hazard ratio was 0.62. In the PD-L1 high group, 0.66. Remarkably similar across 1-year survival rates across PD-L1 subsets, 60 to 70%. We also saw the PFS benefit, 6.7 months with nivo-ipi chemo versus 5 months with chemo alone. It's a hazard ratio of 0.68. And when we look at those Kaplan-Meier curves for PFS, we don't see that initial drop. We don't see that crossing of the early curves, really that 2 cycles of chemotherapy preventing benefit. Some propose that may be countering hyperprogression, but in any case, we see sort of the favorable early benefit from adding chemotherapy and that long-term tail with the dual checkpoint blockade.
So I'm going to talk about CheckMate-9LA. So while CheckMate-227 was a long time coming, and it took a while to have approval for nivolumab and ipilimumab on the CheckMate-227 regimen, 9LA kind of came on us all of a sudden. So 9LA was a randomized Phase 3 trial for all histology lung cancer, and the control arm was standard histology-based chemotherapy. The experimental arm was the nivolumab and low-dose ipilimumab regimen from CheckMate-227 plus 2 cycles of chemotherapy. The reason for the 2 cycles of chemotherapy is that with immune therapy, sometimes we will see early progression, and that's particularly a concern in patients that have a high tumor volume or are symptomatic from their cancer. So this regimen gave only 2 cycles of chemotherapy to prevent early progression, avoid long duration toxicity from chemotherapy, and then also provide the double immune therapy for a chance for a higher number of immune responses that will give us really long duration of benefit and hopefully long-term benefit at 3 and 4 and 5 years. So in this trial, clearly the 9LA regimen was positive, it was superior to chemotherapy, and it was superior for overall survival, progression-free survival, and overall response rate. The duration of response was better for those that responded to treatment, and the progression-free survival was better for the 9LA regimen compared to chemotherapy. Now, the 9LA, the primary endpoint was overall survival compared to chemotherapy for all PD-L1 types. So the FDA approval for the 9LA regimen is for any PD-L1 type, positive or negative, in non-small cell lung cancer. So the way that the CheckMate-9LA regimen was unique was that it looked to give some chemotherapy at the beginning to avoid early progression of the cancer, but minimize the exposure to chemotherapy toxicity. So only 2 cycles of chemotherapy were given. And this is the period where in immune therapy alone trials, we will sometimes see rapid progression of the cancer, and in which the immune therapy arm will look inferior to the chemotherapy arm. So I think that this 9LA strategy with 2 cycles of chemotherapy was successful. We can look at the progression-free survival curve, and early on, the Nivo-Ipi containing arm was not inferior to the standard chemotherapy arm, but we only gave the chemotherapy for 2 cycles, and we don't see as much cumulative sort of grade 3 and 4 toxicity that we see in some of the chemotherapy doublet trials, where patients receive a standard course of chemotherapy plus immune therapy. So I think that the strategy for 9LA was successful in that it minimized the exposure to chemotherapy, but prevented the early progression that we sometimes see with immune therapy alone.